Okay, let's go. Okay, today we are gonna be covering chapter 36, gastrointestinal disorder. We have dysphagia. Dysphagia is difficulty in swallowing, inability to initiate swallowing, sensation that swallowed solid fluid stick in the esophagus, and pain with swallowing. Listen, dysphagia is difficulty swallowing, and odynophagia is pain with swallowing. Okay, those are two different concepts. Dysphagia, we have type 1, that is a problem in delivery of food fluid into the esophagus. Causes are RT, neuromuscular incoordination disorder. Normal sequence is altered or absent, and clinical manifestation may cough or spell the ingested food or fluid, aspirate when attempts to swallow, and work with liquids than solids. Type two dysphagia is problem in transfer of bolus down the esophagus. Cause is outpushing of one or more layer. Diverticular disorder of smooth muscle function, achalasia. Structural interference of the esophageal peristaltic activity, neoplasia, strictures. Abnormal peristaltic activity, clinical manifestation, sensation that the food is stuck in your throat. Okay. We have type 3 is problem in bolus entry into the stomach, cause lower esophageal dysfunction or lesion obstruction. Clinical manifestation is tightness or pain in substernal area during swallowing process. Esophageal pain, we have heartburn. Pyrosis is caused by reflux of gastric content into the esophagus. High acid contents are an irritant to sensory afferent nerve ending in mucosa, causes spasm of esophageal muscle. Clinical manifestations: external burning sensation that may radiate to neck or throat. Most of the time, people get confused with heartburn and chest pain because they describe the heartburn as a chest pain. Esophageal pain, chest pain, caused by esophageal distension or powerful esophageal contraction, may arise from esophageal obstruction or conditions called diffuse esophageal spasm. Clinical manifestation similar to angina pectoris. It's basically a chest pain. Okay. Odynophagia brought on by swallowing. Remember that odynophagia is pain with swallowing. Okay. Esophageal pain, we have chest pain caused in infection of the esophagus or in immunocompromised patient. Clinical manifestation may express as dull, aching chest pain. Swallowing generally worse the sensation of heartburn or chest pain. Abdominal pain may be the first signs of GI tract disorder or many other disorders. Visceral pain is the diffuse. Remember that visceral pain is innervated inside. Okay, the innervation is inside. It's not somatic. It's this pain right here. Most of the time is diffuse. Somatic pain is more localized. Okay. Abdominal pain, we have the referred pain, felt at the location distant for source of pain. Referred pain is that, for example, the myocardial infarction, that you have pain, the pain comes from the heart, then you feel the chest pain, and sometimes they refer as a shoulder pain, arm pain, because they radiate to other part. Okay. Acute instantaneous onset, chronic gradually onset. And right here we have question number 1. Who is here? Susana. And who else is here in the class? And Farag. Okay, perfect. Okay, who know the answer? Nobody know the answer?
B.
What? D.
Yeah.
A patient have knowing poorly localized abdominal pain from inflammation. The answer is A. Remember that uh, visceral pain is poorly localized. Okay, somatic is extremely localized. Refer pains is when you say the patient have, for example, people that have problem in the liver and the liver is close to the diaphragm, then that pain in the liver is touching the diaphragm and the diaphragm refer pain to the shoulder. That's why sometimes people that have problem in the liver, they refer pain to the shoulder. Okay, that's refer pain. Okay, and this dysphagy is problem in the swallowing. Let's keep going. We have vomiting, forceful explosion of gastric contents through the mouth, accompanied by nausea. Causes coordinated sequence of abdominal muscle contraction with reverse esophageal peristalsis. Basically, is that the peristalsis in the esophagus that is going from the mouth to the stomach, they go in the other way. Okay, go from the stomach to the mouth. Intestinal gas results from altered motility or lack of digestive enzymes. Normal cause: swallowing of air, bacteria and digestion action of intestinal contents, neutralization of acid by bicarbonate in the upper GI tract. Intestinal gas clinical manifestation: bleeding, normal eruption of swallowing air, motility disorder, abdominal distensions, excessive flatus. Constipation is when you can't go to the bathroom, okay? And this is a small infrequent or difficulty bowel movement, fewer, fewer than 3 stools per week. This classification is extremely hard and most of the time is according to the normal habit of the patient. Okay, that's why you have to ask the patient what is your normal bowel movement. If your normal bowel movement is one every day, then if you have like 3 days without going to the bathroom, then you start thinking about constipation and uh, problems that can produce constipation. Cause dietary low in fiber, cellulose, lack of exercise, aging, pathologic conditions, altered motility, diverticulitis, obstruction, complication, fecal impactation. In pediatric population, one of the most common cause of constipations is excessive cow milk ingestion. Okay, that's why when you have a child that is over 6 years old, the maximum amount of ounce of cow milk per day has to be no more than 24 because that produces constipation and also anemia. Diarrhea is increased frequency, is the opposite. Okay, diarrhea is the opposite. And we have acute, that's acute infections, emotional stress, leakage of stool around impacted feces. This lack right here, leakage of stool around impacted feces, you have to be very careful because that means that the patient doesn't have diarrhea, okay? That means that the patient have constipation. Sometimes when you have constipation, you have like kind of diarrhea that is fluid and that's not diarrhea, okay? The patient actually is constipated. Chronic lasts longer than 4 weeks. Chronic GI tract infection, alteration in motility or integrity of GI tract, malabsorption, certain endocrine disorder, food allergy, ingestion of irritant, and caffeine. Diarrhea, pathophysiology mechanism, osmotic, secretory, and exudative and motility disturbance. Osmotic, increased amounts of poorly absorbed solutes in the intestines, secretory caused by toxins, exudative is result from inflammatory process, and motility disturbance is decreased transience time to kind with the adsorptive surface. Stomatitis is an inflammation of the oral mucosa caused by pathogenic organisms, trauma, chemical irritations, chemotherapy, radiation, nutritional deficiency, autoimmune disorder, idiopathic. Treatment depend on the cause. Use adequate oral hygiene, topical mucus barrier, and corticosteroid may be of some benefit. We have stomatitis, is acute herpetic stomatitis. We have cold sore caused by herpes simplex virus, clinical manifestation, fever, pharyngitis, predominant tingling and itching, vesicles of erythematous base that rupture, leaving a painful ulcer. Most of the time when you have herpes simplex virus infection in any part of your body, most of the time they produce vesicle. That's the main characteristic. Okay. Treatment: antiviral medication, fanciclovir, valacyclovir, or valacyclovir. Okay, that's another medication. Gastroesophageal reflux disease (GERD) is a bad flow of gastric contents into the esophagus through the lower esophageal sphincters. Inflammation caused by reflux or highly acid material. Esophagitis cause any condition or agents that alter closure strength of lower esophageal sphincter or increase abdominal pressure. Fatty food, caffeine, large amount of alcohol, cigarette smoking, pregnancy, anatomic fissures, hiatal hernia, gastroesophageal reflux disease, clinical manifestation, heartburn, regurgitation, chest pain, dysphagia, and one of the main characteristics is nocturnal asthma. Okay, those patients have cough at night. Treatment: increase lower esophageal sphincter pressure, enhancing esophageal clearance, improving gastric emptying, suppressing gastric acidity, avoid tobacco and aggravated food and drink. Gastroesophageal reflux: the treatment is over-the-counter antacid or antihistamines, blocking medication for occasional GERD. PPI is the best medication. Okay, that's the best medication. Is the one that actually is gonna work. Okay, the other medication is like alternative treatment. The real treatment is PPI for 6 weeks. Over GI endoscopy for ongoing symptoms, endoscopic dilation for strictures, surgical intervention, or endoscopy. You do endoscopy if you have alarm symptoms. Okay. Gastroesophageal reflux disease complication, Barrett esophagus. Barrett esophagus is basically a complication of exactly of the GERD because a lot of acid going to the esophagus, then they change the epithelium. That's what means Barrett esophagus. It's a metaplasia. Okay, progression can lead to ulcer, fibrotic scarring, esophageal structure, pulmonary symptom, cough, asthma, and laryngitis from reflux in breathing pathways. Hiatal hernia is a defect in the diaphragm, allowing a portion of the stomach to pass through the diaphragm, opening into the thorax. Rates increase with age. Women more than men have sliding hernia, most common, and paraesophageal hernia is a rolling mixes. The worst is paraesophageal hernia, okay, because that may pressure on the part of the stomach that is protruding through the to the diaphragm, and that can produce necrosis. Hiatal hernia, intra-abdominal pressure increase, such as ascites, pregnancy, obesity, chronic straining, or coughing. Clinical manifestations similar to heartburn, chest pain, dysphagia can be life-threatening if large portions of the stomach become incarcerated. Treatment similar to GERD surgery for acute incarceration or intractable reflux. Most of the time, you don't do surgery in hiatal hernia in the sliding, because remember we have paraesophageal and sliding. Sliding most of the time is asymptomatic and you don't do the surgery. Mallory-Weiss syndrome is a bleeding by a tear in mucosa and submucosa of the cardia or lower portion of the esophagus. Esophagus. Cardia, when they say cardia, is the cardia sphincters. Okay, cardia sphincter is the lower portion of your esophagus. Primary causes are forceful prolonged vomiting, clinical manifestation, vomiting of blood, and passage of large amount of blood rectally after an episode of forceful vomiting, epigastric or back pain. This condition is common in alcoholic patients. Mallory-Weiss syndrome diagnosis, endoscopic examination, treatment, blood transfusion, but in most cases bleeding stops spontaneously, control of active bleeding, endoscopy, multiple electrolyte coagulation with similar technique, epinephrine injection, or interventional radiology procedures. Surgical intervention may be necessary. Esophageal varices is a complication of portal hypertension resulting from alcoholic or viral hepatitis. In developing countries, schistosoma, a species of liver fluke may cause. Schistosoma is a parasite. Affects more than half of cirrhotic patients, high mortality rate. Gastritis is inflammation of the stomach lining. Acute, we have precipitated by ingestion of irritant substance, example, alcohol, aspirin, NSAID, viral autoimmune. Clinical manifestation may be asymptomatic or have anorexia, nausea, vomiting. Postprandial discomfort, hematemesis is when you vomit blood. Treatment, remove the offending agent. Gastritis, chronic gastritis. The most common cause of chronic and acute gastritis is this one, H. pylori. Okay, complication could be the peptic ulcer disease, atrophic gastritis, gastric adenocarcinoma is a type of cancer, mucus-associated lymph tissue lymphoma, another type of cancer, decreased acid and intrinsic factor. We need intrinsic factor is essential for absorption of vitamin B12. Okay. Gastroenteritis is inflammation of the stomach and small intestine, usually self-limiting. Chronic, usually result from another GI disorder. Acute, direct infection by pathogenic bacteria or bacterial toxin. Gastroenteritis clinical manifestations is diarrhea, abdominal discomfort or pain, nausea, vomiting, fever, malaise. Treatment, replace fluids and electrolytes, especially in elderly and children, okay, because dehydration is a really bad condition for those population. Peptic ulcer disease. Peptic ulcer disease is a disorder of upper GI tract caused by action of acid and pepsin. And the pepsin is the enzyme that digests the protein. Injury to the mucosa of the esophagus, stomach, and duodenum range from slight mucosal injury to severe ulceration. Increase in factors that tends to injure the mucosa relative to factors that tend to protect. Peptic ulcer disease causes We have no related between diet and peptic ulcer disease, NSAID, stress, glucocorticoids, smoking, genetic, H. pylori. Again, H. pylori is the most common cause. Drive in acid conditions, slow rate, cleans H. pylori, promote ulcer healing. Of course, you treat the H. pylori, you kill the H. pylori, then you heal the ulcer. Peptic ulcer disease, we have gastric and duodenal. That's according to the location in your body, caused by breakdown of protein mucosa layer of the normal, prevents diffusion of acid into the gastric epithelium because of chronic irritation, aspirin, NSAID, alcohol, and bile acid. Duodenal, inappropriate excessive secretion of acids, increased basal activity of vagus nerve, stimulated pylori antrum cell to release gastrin to act on gastric parietal cell to release hydrochloric acid, result in high level of hydrochloric acid. Peptic ulcer disease, clinical manifestations, epigastric burning pain that is usually released by intake of food, especially dietary product or antacids. You have to be very careful with dietary product because that worsens the condition, that don't treat the acid, okay, the acid reflux. Pain of gastric ulcer typically occur at an empty stomach but may present soon after a meal. Pain of duodenal ulcer classically occur 2 to 3 hours after pain. Listen, this is you have like a guide to distinguish the gastric from the duodenal. Okay, gastric is pain with eating. Duodenal is pain with no eating. Okay, after you eat like 2 or 3 hours after you eat, that means that the food that you eat reach to the duodenum, then you feel the pain. Life-threatening complications such as GI bleeding may occur with no warning. Diagnostic upper GI, barium contrast, radiography, or by endoscopy. Gastric ulcer should be visualized by endoscopy and biopsy to rule out malignancy. Testing for H. pylori. Always you have to test for H. pylori because it's the most common uh, risk factor, okay, and the most common cause of peptic ulcer disease. Treatment encourage healing of the injured mucosa by reducing gastric acid, prevent recurring H. pylori antibiotic, H2 antagonists, PPI, sucralfates. Okay, out of all these treatment, you have to know all of them. Well, the main one is that you have to treat the H. pylori. It's a triple antibiotic therapy and PPI. Okay, those are the main medications. Smoking cessation, avoid of ACE, ASA, that means aspirin, and NSAID, stress reduction, avoid irritant food that exacerbate symptoms, caffeine beverage, alcohol, complication, perforation, and bleeding. Ulcerative colitis. Now we have inflammatory bowel disease. In inflammatory bowel disease, we have two: ulcerative colitis and Crohn's disease. Okay, ulcerative colitis is a chronic inflammatory disease of the mucosa of the rectum and colon. Large ulcer from mucosal layer of colon and rectum begin as inflammation at base of crypt of Langerhans. Those are structures that are present in the GI. Okay, damage result, abscess formation in crypts, abscess begin to coalesce, large ulceration develop in the epithelium. Listen, ulcerative colitis, colitis means colons, that means that the ulcerative colitis always is going to involve the colon. Okay, associated with increased cancer risk, have exacerbation and remission, hallmark clinical manifestation, and bloody diarrhea, and large abdominal pain. Okay, That's one of the main conditions, okay? Bloody diarrhea. Treatment: corticosteroid, broad-spectrum antibiotic, salicylate analog, immunomodulating agent, azathioprine, mercaptopurine, intravenous allowed by oral cyclosporine for refractory infliximab. Now we have Crohn's disease. Crohn's disease, also called regional entering of granulomatous colitis, affects proximal portion of the colon or terminal ileum. The most common one is terminal ileum and always spare the colon or spare the rectum. Okay, ulcerative colitis always involve the rectum. Okay, Crohn's disease is a skip lesion. Okay, the lesions are skip. Okay, ulcerative colitis is continuous lesion. Okay, another characteristic is, and it's not always, okay, another characteristic of Crohn's disease is that the diarrhea is not bloody, but it's not always, okay, because if you have a Crohn's disease that involves the colon, then you have bloody diarrhea. Okay, one of the main characteristics is this: they produce strictures, and those strictures produce stenosis and fistulas. Fistulas is the most common characteristic. Okay, fistula is a communication. Okay, in your body, could be a communication colon to the urinary bladder, colon to any part of your body. Okay, any part that touches the colon make communication, and that's a fistula. Crohn's disease clinical manifestation: intermittent bout of fever, diarrhea, if bloody not as necessary as ulcerative colitis, constant chronic right lower quadrant pain, may have right lower quadrant mass, tenderness. Treatment: alleviating and reducing inflammation, smoking cessation, drug similar to ulcerative colitis, and there is no cure. Treatment: prednisone and sulfasalazine, antibiotic metronidazole, azathioprine, 6-methaxypyrin, methotrexate, and so on. Enterocolitis, we have antibiotic-associated colitis. Pseudomembranous enterocolitis is acute inflammation and necrosis of large intestines caused by Clostridium difficile, mediated by bacterial toxins. Clinical manifestation: diarrhea, abdominal pain, fever, leukocytosis, sepsis, colonic perforation, rare. Listen, this is the clinical. Let me see if we have the clinical presentation. Right. No. Okay, the clinical presentation for pseudomembranous colitis, that's the name of this condition, is that the patient is taking antibiotic and they develop diarrhea. Okay. Treatment: stop the current antibiotic is possible. Treat ischemia, treat contributing conditions. Oral antibiotic metronidazole or vancomycin. Recurrent is common, rare fecal transplant. Okay, that's the extreme condition. Okay, that if you give the medication and the patient don't get better, then you give this. Okay, but most of the time they get better with the medication. Metronidazole and vancomycin is oral vancomycin. Okay, is the only way that you give oral vancomycin. And also we have another medication. Okay, right here we have equations, and the equation said which information is correct regarding pseudomembranous colitis. Pseudomembranous colitis developed because of overgrowing of Clostridium difficile, does not recur following treatment, is a major cause of diarrhea in premature infants, may also be called regional enteritis. What is the answer? Nobody know. Okay, remember that pseudomembranous colitis is always produced by Clostridium difficile. Okay, The real pathophysiology of pseudomembranous colitis is that when you give antibiotic to the patient, you kill the flora. One of the bacteria that is in the GI flora is the Fragile. It's a bacteria called Fragile. You kill the Fragile and then proliferate the Clostridium difficile, and you develop the condition. Necrotizing enterocolitis is occur in premature infant. That basically is the most common characteristic. Okay, premature infant or infant that is in formula. Okay, because formula also produce necrotizing enterocolitis. Okay, characterized by diffuse or patchy intestinal necrosis with sepsis. Etiology: bowel ischemia, perinatal oxygen deficit with ischemia to viscera, use of hypertonic feeding formula in newborn infants. Necrotizing enterocolitis, clinical manifestation, distant abdominal stomach, intestinal perforation, treatment, fluid replacement, antibiotics, surgery for ischemia and perforation. One of the main characteristics of necrotizing enterocolitis is that when you take an image, an X-ray, they are going to show pneumatosis intestinalis. Okay, necrotizing enterocolitis, Tiffitis, specialized necrotizing enterocolitis, adult cancer patient with neutropenia, grave prognosis. Appendicitis is inflammation of the vermiform appendix, obstruction by fecally, that's the most common condition that produce appendicitis, clinical manifestation, periumbilical pain, right lower quadrant pain, Mark-Brunner's point. You have to know what is the Mark-Brunner's point, okay? Not for the class, for your future life, okay? Classic, but may be anywhere, nausea, vomiting, fever, diarrhea, and so on. Treatment: immediate surgery to remove the appendix, antibiotic with fluid and electrolyte replacements. Untreated appendicitis can rupture the appendix and produce peritonitis, that is inflammation of the peritoneum, and is a worse condition. Diverticular disease: presence of diverticular is herniation in the colon. Diverticulosis when you have a lot of diverticular, result from low intake of dietary fiber, result in high intra-abdominal pressure, clinical manifestation, diverticulosis asymptomatic, diverticulitis, inflamed diverticular fever, acute lower abdominal pain, leukocytosis. Listen, appendicitis is pain in the right lower quadrant. Diverticulitis is pain in the left lower quadrant. Okay? Most of the time, diverticulosis, in medicine we call left side appendicitis. Treatment: antibiotic, surgical for abscesses. Irritable bowel syndrome: alteration, diarrhea, and constipation accompanied by abdominal cramping, pain with no identifiable pathology process in the GI tract, also called spastic colitis and irritable colon syndrome. Etiology unclear, but slow wave activity of the bowel is increased. Irritable bowel syndrome, clinical manifestation, diarrhea or constipation. Listen, one of the main characteristics of irritable bowel syndrome is that get better after you have a bowel movement. Okay, if you have diarrhea or constipation, when you have the bowel movement, the pain get better. That's one of the main conditions, and most of the time it's related with psychiatric problem. Okay, treatment: anti-diarrhea agent, antispasmodic medication, high fever diet. Support group is extremely important. Internet-based resource and alternative therapy. Intestinal obstruction, partial or complete blockage of a small or large bowel, mechanical and functional. Mechanical is adhesion, that's the most common uh, I mean condition that produce intestinal obstruction. And adhesion is that when you have a surgery, years later you can develop the adhesion. Is basically that the internal organ they stick one to another. They stick together and that produce the obstruction. Hernia tumor impact the feces, volvulus into subsections. I don't know if we are gonna cover these two conditions because those are two conditions, volvulus and into subsection. Functional condition that inhibit peristalsis. Ogill syndrome, characterized by recurring bound of ileus, is a rare. Ogilvy, I don't know the pronunciation of this, and that have an special characteristic in the image. Intestinal obstruction, most common size, small intestine, contributing factor, previous abdominal surgery because that produces adhesions, congenital anomaly of the bowel, metastatic cancer, particular cancer of the intestinal tract or female reproductive organ, fluid, gas, water, and electrolyte accumulate in the bowel. Clinical manifestation depend on type of and duration. Mechanical obstruction, increased bowel sound initially accompanied by abdominal pain, nausea and vomiting. Functional obstruction, absence of bowel sound. Clinical manifestations: upper jejunal area, vomiting, dehydration, and electrolyte depletion. Distal portion of the small uh, lower or ileums. Constipation may be an early manifestation. Treatment: remove mechanical blockage, surgical intervention or decompression with intestinal tubes. Fluid electrolyte replacement, if left incorrect, may cause perforation, and that is a worse condition that produces peritonitis, and the patient has to go to ICU, intensive care unit. Volvulus is a twisting of the bowel and on itself causing intestinal obstruction and blood vessel compression ischemia. That condition is a real emergency because if you don't untwist the bowel, then that produces ischemia, and then you have to do a surgery to remove that part that is ischemic. Result from anomaly of rotation, ingest foreign body, or adhesion cannot always be determined. Common sites are secant and sigmoid colon. Swelling, tight twisting of bowel, impaired blood flow to bowel, impaired blood flow leading to gangrene, necrosis, and perforation. Life-threatening condition. Trick vary according to severity and location. Surgical intervention and decompression. Intussusception is a telescopic invasion of a portion of bowel into the adjacent bowel, causing intestinal obstruction, most often in infants. Is extremely common in infants under 2 years old, male more than female. Treatment: surgical treatment. Gangrene, shock, and perforation is surgical treatment delayed. Listen, the real treatment for intussusception is a uh, you put you may produce an colonoscopy and then you put air inside, okay, and that is a diagnostic because you're gonna see the intussusception in the image, and it's also the treatment, okay. If you don't resolve the condition with that, then you do the surgery, okay. But the first treatment is a colonoscopy and then you put air. Megacolon, congenital or acquired massive dilation of colons, cause prolonged constipation. Pseudomembranous colitis may result in acute megacolon, surgical emergency. Hirschsprung's disease. Hirschsprung disease is basically a type of megacolon family congenital disorder of the large intestine in which the autonomic ganglia are reduced or absent. Occur 1 to 5,000, most common found in infants and children, male more than female. Clinical manifestation: profuse diarrhea, hypovolemic shock, intestinal perforation, stasis of stool and megacolon may occur, fecal stagnation, enterocolitis with bacteria overgrowth, treatment, colonic lavage, and surgical intervention. The way that you diagnose this condition is with biopsy. Failure of small intestine to absorb normal digestive one or more dietary constituents, thus malabsorption disorder, cause enzymes abnormality, infection, radiation, enteritis, mucosal dysfunctions, chronic Crohn's disease, celiac disease, tropical sprut, surgical alteration that affect transient time of absorptive surface area, clinical manifestation, diarrhea, passage of inappropriately processed intestinal content, abdominal pain. We have celiac disease, also called celiac sprut, family intolerance of gluten-containing food lead to inflammation and atrophy of the intestinal villi, impaired nutrient absorption, reduced surface area, decreased brush border enzyme, increased for intestinal malignancy. Diagnosis: intestinal biopsy, anti-tissue transglutaminase antibody as one of the main tests to diagnose celiac disease, immunoglobulin A endometrial antibody, treatment, gluten-free diet, supplements, iron, folate, B12, fat-soluble vitamins A, D, E, and K, oral corticosteroid or other immunomodulating agent for refractory tropical sprut, also called enteropathy, malabsorptive syndrome of unknown cause, bacterial overgrowth of large intestines, produce fermentation that damage mucosa of small intestine atrophies result in malabsorption along with B12 and folic acid deficiency, prevalence in equatorial countries, adult more than children, and the treatment is antibiotic. Tropical sprut is clinical manifestations: severe diarrhea with blood-tinted stool, abdominal distension, steatorrhea is fat in the stool. Treatment: periodical depend on area, anti-diarrhea, prolonged antimicrobial therapy, replenishment of lost vitamin. Dumping syndrome, dumping syndrome, dumping of the stomach content into the small intestine because of impaired gastric emptying, loss of pyloric sphincter regulation, common after gastrectomy or gastric surgery. The famous gastric bypass, people that they have a surgery to reduce the stomach, they develop this type of disease, okay, that produce diarrhea. Let me see, large volume of hyposmolar food is dumped rapidly into the small intestine, osmotic shift of water into the lumen, and diarrhea. Rapid absorption of large amount of glucose lead to an excessive rise in plasma insulin with rebound hypoglycemia. Clinical manifestation: diarrhea, abdominal pain, rapid fall in blood glucose level 1 to 3 hours after meal. Treatment: eating a small amount of meal. Okay, that's the treatment. Instead of eating like 3 times a day, then you put the patient to eat like 6 times a day, and the amount is little. Short bowel syndrome is severe diarrhea and significant malabsorption developed after surgical removal of large portions of the small intestine. That the name gives you what is the problem, okay? Rapid transit time of reduced surface areas for absorption if ileocecal valve removed, diminished ability to absorb nutrients, short bowel syndrome, clinical manifestation, diarrhea, malabsorption, treatment, gradually increasing oral intake, temporary or indefinite intravenous nutrient support, esophageal cancer. Now we start with the neoplasia. Okay, account for 1 to 2% of all cancer. Men more than women, risk factor, genetic, dietary high in nitrosamine contents. That's common in the Asia population. No Asia population here in the United States. Asia population in Asia. Okay. Chronic severe reflux, Barrett esophagus, environmental conditions, smoking, alcohol. Here in the United States, those are the most common: smoking, alcohol. Prognosis: poor, very high degrees of metastasis. Treatment: stent placement, tumor ablation through heat-proof laser, surgical radiation, chemotherapy. Gastric carcinoma, prevalent in Japan, extremely common in Japan due to this, the nitrosamine. Okay? Men uh, more than 30 years, 5 year survival rate 20%, stage early and advanced. Always when you have a cancer, you have to stage the cancer. Okay. Gastric carcinoma, risk factor, H. pylori. That's extremely important. That's why you have to treat the H. pylori. Epstein-Barr virus, genetic disease habits, environmental factors, smoking. Aspirin has a protective effect. Clinical manifestation: early, non-advanced anorexia, weight loss, and GI bleeding. Treatment: surgical removal. Small intestine neoplasia, benign or malignant, account for 5% of GI tumor, more than 50 years old. Clinical manifestation depend on type and stent, partial or complete obstruction of the small bowel may occur, biliary stasis and jaundice, bleeding and ulceration. Treatment: surgical removal of the uh, cancer. Colonic polyps, any protrusion in the GL lumen may precursor lesion in development of colon cancer, benign or malignant. Sessile polyps raise protuberance with a broad base. Pedunculated polyps attached to bowel, followed by a stalk that is narrower than the body of the polyps. This one, pedunculated, is easy to remove. This one is the really hard to remove, the sessile polyp. Clinical manifestation, usually none, may cause occult or gross bleeding, abdominal pain. That's why we have to do the colonoscopy. Okay, colonoscopy starts at 50 years old, every 10 years until 75 years old. Treatments vary according to site, type, and location. Usually removed through a scope. Scope is colonoscopy. That's the scope. Colon cancer, second only the lung cancer as a cause of cancer death. Risk factor increase after age 40, high fat, lower fiber diets, polyps, chronic irritation or inflammation, and hereditary. I have to check this information because colon cancer is number 3, it's not number 2. Colon cancer screening guideline for the individual at average risk: colonoscopy every 10 years, and you start at 50 years old. Important hereditary condition: familial adenomatous polyposis, at least 3 close relatives with colorectal cancer. Colorectal cancer involves at least 2 generations and more, and one or more cases of colorectal cancer occurring before age of 50 years old. If you have this condition, then colonoscopy start 10 years before the, that your relative developed the cancer. Okay, that means that your relative developed the cancer at 55, then you do colonoscopy at 45. If the relative developed the cancer at 45, you do colonoscopy at 35. Colon cancer, clinical manifestation, right side, black, there is two, left side, intermittent abdominal crampings, and fullness, rebound or pencil-shaped stool, blood or mucus stool, rectum, change in bowel habit, urgent need to defecate on awakenings. Colon cancer prognosis, early detection, better prognosis depend on the extent of tumor invasion, cell type, degree of dysplasia, tumor genetics, present or absent of metastasis. TNM is the classification. Treatment, surgical remove, colostomy is the type of surgery, chemotherapy, radiation, or both. And here we have question number 3. The most common location of carcinoma developing in the GI tract is the, what is the answer? The answer is B, large intestine, okay? And psychosocial aspects and lifestyle changes affect patient and family. Alteration in GI function may cause great emotional distress and inability to participate fully in social activity. Most of the time, when you have patient with diarrhea, you have to check for psychiatric problem. Okay, and we finish right here with chapter 36. Let's go to chapter an equation. Hello, hello, hello. An equation?
Hello? Yeah.
Yes, no, no. Then let's keep going to the next slide. The class today is gonna be long because the last PowerPoint is 140 slides. Okay, now we have alteration in function of the gallbladder and exocrine pancreas. Remember that the pancreas have exocrine and endocrine function, okay? A structure and function of the pancreatobiliary system, gallbladder and cystic duct forms a controlled system to deliver bile to the intestinal tract. Gallbladder, distensible sac about 30 to 50 ml, cystic duct is a communication that connect the hepatic duct to common bile duct. Now we have uh, intrahepatic, hepatic, and common bile duct. Common bile duct 3 inches long, terminate at ampulla of butter. That's part of the pancreas. Forms termination point of main pancreatic duct, drain tail of pancreas, ampulla of bladder form the major aqueduct for digest secretion to enter intestinal tract. Uh, Let me see. 3 to 4 week gestation, hepatic diverticulum form from the primary foregut, composed of specialized progenitor liver cells, eventually form entire liver, biliary tree, ventral pancreas, dorsal pancreas from separate outcropping of cell. with 5 dots seen in hepatic diverticulum, cranial from liver, caudal develop into the gallbladder, and basal form the ventral pancreas. Second trimester, fetus produce bile that give coloring to the fetal meconium. Bile composition primarily water, electrolytes, organic solids, low protein contents, additional components, bile acid primary and secondary, pigment, cholesterol, phospholipids produced by hepatocytes in liver, storage in gallbladder, bile function, aids in digestion of lipids, transport of waste products, bilirubins, immunoglobulins, toxin, and cholesterol. Gallbladder, concentrate and storage bile, fasting stage, muscular sphincter of ampulla of bladder is contracted, promote flow of bile into the gallbladder, half of the bile storage, half flow into the duodenum, absorption 90% of water in bile, absorption from bile in 4 hours. Gallbladder, bile float, first morning meal, hormonal and neuroregulation, concentration of gallbladder-related concentrated bile into duodenum, bile acid eventually absorbed again in the intestinal ileums, travel by partial circulation to secrete again into the bile, a small amount of food enter the colon, and so on. Bile salts, dual properties, digestion and absorption of fat from small bowel, methyls surround lipids and allow them to go into the solutions, hydrophilic, soluble in water, hydrophobic, insoluble in water. And here we have question number 1. Which waste product does bile primarily transport? We know the answer. Okay, always remember bile with bilirubin. Okay? Pancreatic functions, we have endocrine pancreas secretes hormone to the bloodstream, insulin, glucagon, and somatostatin. Exocrine pancreas secrete 1 liter of digestive juice into the duodenum every 24 hours. Pancreas components, we have lobar composed of 2 fused organs, dorsal and ventral, pancreatic juices, digestive enzymes, amylase and lipase. Those enzymes are secreted in the active form, precursor or proenzymes. Trypsinogens is an inactive form of trypsin release stimulated by CCK, that is cholecystokinin, and secretin. Okay, pathophysiology of cholesterol and gallstone formation. Majority of gallstones are cholesterol. 3 phases: supersaturation of bile with cholesterol, precipitation of cholesterol, nuclear action of crystal, and hypomotility. Hypomotility means there is no movement, okay, or little movement. The physiology of cholesterol gallstone formation. Lecithin helps keep cholesterol from precipitating into the crystal in bile. Crystal of cholesterol may initiate gallstone formation. Relative concentration of cholesterol, lecithin, and bile acid determine likelihood of cholesterol gallstone formation. That's why we have to take care of cholesterol. The bad cholesterol, remember that we have 2 types of cholesterol. Pathophysiology of cholesterol gallstone formation, risk factor, prolonged fasting or rapid weight loss, pregnancy or contraceptive, obesity, sex, variety of medical factors. We have pigmented stones is 25% of all the stones contain of mixture of pigmenting polymerase and calcium salt. Black pigmented stone most common may be idiopathic or associated with cirrhosis or hemolysis. Brown pigmented stone differ in composition, much more common in developing countries, associated with biliary parasitosis, bacterial colonization, and infection. Cholelithiasis is also called gallstone, is a stone in the gallbladder. Etiology: Native American, American Caucasian, more common in women. Adult may be associated and not need treatment. Children usually from underlying condition and need gallbladder removed. The easiest way that you remember cholelithiasis is the 4F. Okay, you have to remember the 4F. Okay, let me go back. Cholelithiasis, you have to remember the 4F. Female, 40. Most of the time, the female is in the 40. Fertile, because they are fertile, they can give birth, and fat. Chronic cholelithiasis is biliary colic related to intermittent obstruction of cystic duct precipitated by meal, persistence of epigastric right upper abdominal pain, often radiated to the back, nausea, vomiting, sweating, flatus, increased study for more than 50 minutes, fatty food intolerance. Chronic cholelithiasis diagnosis: ultrasound, treatment, watchful waiting. Cholecystectomy is the removal of the gallbladder. Chemical dissolution of gallstones. Lithotripsy is when you break down the stone. Cholecystitis. Cholecystitis is an inflammation of the gallbladder wall, causes fibrosis and thickening related to continued presence of gallstone. We have two types: acute and chronic. Acute is acute inflammation of the gallbladder wall. Etiology: cholelithiasis present in 90% of the patients. Obstruction of the cystic duct present in almost all patients relative to stasis of bile. Bacterial infection may be present. That's why most of the time those patients have fever. Okay. Acute cholelithiasis, if untreated, escalating gangrene may occur, rupture, peritonitis, septic shock, localized abscess, and sometimes they produce a fistula. Acute cholelithiasis, clinical manifestations: severe right upper abdominal pain radiating to the back, abdominal tenderness, fever, leukocytosis, mild elevation of bilirubin and serotransaminase. Diagnosis: abdominal ultrasound, presence of a stone, thickening of gallbladder wall, and hide scan, CT, MRCP, RCP. Those are images. Acute cholecystitis treatments: laparoscopy, cholecystectomy, mainstay of therapy, antibiotic amines, percutaneous catheter drainage or endoscopic drainage with stent placement. This procedure, if the patient is poor candidate to surgery, then you do this procedure. Gangrene, epyema, and emphysematous chains surgical emergency. Acute cholecystitis treatment: pain management, chemodissolution, non-surgical use of bile acid, organic solvent to dissolve the gallstone, lithotripsy. Acute cholecystitis: we have a calculous cholecystitis, occur in patients without persistent gallstones, male over 50 years old tend to occur in the setting of major surgery. That's one of the main characteristics. Clinical illness, trauma, burn-related injury, or TPN. TPN means total parenteral nutrition. Rapid development of gangrene, perforations, ephysematous cholecystitis, and empyema. Chronic cholecystitis, chronic inflammation of the gallbladder wall related to persistent low-grade irritation from gallstone, recurrent attack of acute cholecystitis, predisposing factors, diabetes, obesity, clinical manifestation, asymptomatic intermittent biliary colic, or symptomatic acute attack lead to complications. This right here, especially porcelain gallbladder, is if you have this, you have to remove the gallbladder, okay, because that is a precursor of cancer. And we have question number 2. A patient have acute symptomatic cholecystitis from gallstone. Which treatment should the nurse prepare the patient to receive? Question number 2. Okay, if you have gallstone, you have to remove the gallbladder, okay? The treatment is laparoscopic cholecystectomy. You have to be very careful with this word right here, laparoscopic, okay? Because we have laparotomy and laparoscopic, okay? Laparoscopic is the minimal invasive procedure, and laparotomy is an open procedure, okay? It's basically an emergency surgery. Biliary malignancy, rare, only 1 to 2 cases tend to be asymptomatic and progress insidiously until well-advanced risk factor, uh, primary sclerosis cholangitis, infestation with liver flakes, biliary malignancy, clinical manifestation, right upper quadrant pain, and jaundice associated with biliary obstruction. Treatment, surgery for cure in fewer than 10% of the case, chemotherapy and radiation therapy, palliative, stents, and other procedures to alleviate biliary obstruction. Now we move to the pancreas, okay? Acute pancreatitis, inflammation of the pancreas, autodigestion of the pancreas from enzymes, activation, predisposing factor, biliary tract disorder, hypertriglyceridemia, ethanol associated, that's the most common one. 3 pathway, obstruction of the pancreas due to the stone, acinar cell injury, and defective intracellular transport. Acute pancreatitis, clinical manifestation, study burning pain in the epigastrium or lower left upper quadrants, increase in intensity, severe tenderness of palpation, radiating or penetrating to back. That's the main characteristic of pancreatic pain. Is an abdominal pain in the epigastric region that radiates to the back. Okay? Nausea and vomiting, abdominal distension, hypoactive bowel sounds, low-grade fever. Diagnostic laboratory lipase preferred test. Most of the time we measure lipase and amylase, but the most accurate is lipase. Remember that amylase is also produced in your mouth, okay? Abdominal x-rays, abdominal ultrasound, CT of the abdomen, that's the gold standard, okay? To diagnose, in acute pancreatitis, the gold standard is the lipase, okay? In chronic pancreatitis, you have to do the CT scan. Acute pancreatitis treatment for mild to moderate, reduce pancreatic secretion, conservative management, withhold of feeding, nasogastric suction of dynamic ileus, IV fluids, analgesic. Is severe, usually in ICU, nutritional replacement, prevents tissue breakdown, may TPN, calcium and magnesium administration, control of hypoglycemia, prevent respiratory failure, acute respiratory disease, because that's a complication. Treatment for severe mechanical ventilation and hemodialysis may be needed. Bacterial infection, antibiotics, surgical interventions, access of hemorrhage. Surgical intervention is the last option. Okay, most of the time when you have a pancreatitis, you have to try to avoid open the patient, because once you open the patient, start the complication. Acute pancreatitis complication, pseudocyst is a collection of fluid within or adjacent to the pancreas, abdominal ulnar or mass. Pancreatic ascites is a percentage leakage of pancreas duct into the pleural space and mediastinum. Treatment is prolonged parenteral nutrition and stent. And we have question number 3. Okay, which of the following diagnostic tests is considered the gold standard for evaluation of the pancreas when acute pancreatitis is suspected? What is the answer? Listen, this question, the answer is A, okay? Because here we have decreased lipase. If you put increased lipase in acute pancreatitis, the gold standard is acute lipase, increased lipase, okay? Chronic pancreatitis, chronic inflammation lesion in the pancreas associated with alcohol intake can progress even if alcohol consumption is stopped, does not increase risk for cancer, predisposing factor, alcohol, idiopathic, hereditary, trauma, and in children the most common uh, predisposing factor for chronic pancreatitis in children is cystic fibrosis. Chronic pancreatitis pathogenesis is persistence of chronic inflammation lesion in the pancreas. Key element necrosis of exocrine parenchyma followed by fibrosis leading to calcification. That's what you see on the CT scan, the calcification, obstructive flow of pancreatic juice, persistent symptoms secondary to pancreatic dysfunction over weeks or months. Chronic pancreatitis clinical manifestations: bout of acute pancreatitis with progressive endocrine and exocrine dysfunctions, diabetes, malabsorption, weight loss, insidious onset of steady, boring epigastric pain radiating to the back, nausea after about 5 years of continual pain, decrease in symptoms, pain, burnout. Chronic pancreatitis complications: pseudocyst, pancreatic ascites, obstruction of the common bile duct, surgical or endoscopic intervention, thrombosis of partial of splenic vein may lead to GI hemorrhage related to gastric varices, Peyronie ulcer disease. Chronic pancreatitis diagnosis: we have history, physical examination, laboratory. Laboratory, you have to be very careful because in chronic pancreatitis, lipase and amylase are normal. Abdominal X-ray that you see calcification, ultrasound, CT, MRCP, ERCP. Chronic pancreatitis treatment: pain control, absolute abstinence from alcohol, analgesic, surgical intervention, celiac plexus block, pancreatic sphincterectomy, management of single or multiple stones, endoscopic drainage, pseudocyst. Treatment: biliary pancreatic stent, obstruction of the bile duct or main pancreatic duct, Whipple procedure. Whipple procedure most of the time is reserved for pancreatic cancer, not for chronic pancreatitis. Pancreatic enzyme replacement, that's extremely important, and medication, ACE2 blocker and PPI. Chronic pancreatitis treatment, management of endocrine and exocrine insufficiency, low-fat diet, medium-chain triglycerides, pancreatin enzyme supplementation, oral hypoglycemic agent, insulin. Pancreatic cancer, about 2% of all pancreas, ranked fourth among deaths for all malignancy, difficult to diagnose and treat. Median survival rate 1 year. This is an extremely aggressive cancer. Risk factors: cigarette smoking and obesity. One of the main factors worldwide is smoking. Pancreatic cancer, clinical manifestation: pancreatic head tumor, jaundice, malabsorption and weight loss. Pancreatic tail, abdominal pain and nausea. Treatment: surgery and chemotherapy. And the surgery is the Whipple procedure. Any question? We finish right here with chapter 37. Any question? No question? Okay, if you don't have any question, let's keep going to chapter 38. Okay, give me 1 second. I'll be back just in a few seconds. Okay, give me 1 second, please. Okay, let's go, let's go. Now we have liver disease. This chapter is really long because liver have the hepatitis. Okay, but we are gonna go over the most important stuff of hepatitis because you don't have to know a lot about hepatitis. Okay. Okay, let's go. Structure and function of the liver: large parenchymal organ of the body, located in the right upper quadrant of the abdomen, divided into the right and left lobe. We have the Gleason capsule, blood supply of the liver by the hepatic arteries and portal vein, dual blood supply, arteries 25%, remaining from portal vein 75%, portal circulation, afferent blood vessels branch into the liver to form the portal triad, portal vein, hepatic artery, and bile duct. Blood from hepatic artery and portal vein drains into the uh, hepatic sinusoid, surrounded by endothelial and Kupffer cell. Those are the hepatic cell. I mean, Kupffer cell. Those are the macrophages of the liver. Surround sheet of liver cell and hepatic plate. Central vein coalesces into the hepatic vein, empty into the inferior vena cava. Uh, Obstruction to the flow of blood can lead to portal hypertension. Also have a risk of complexity lymphatic drainage system. 80% of the liver may be destroyed before life is threatening. Digestive organs: bile salt secretion for fat digestion, processing and storage of fat, carbohydrate, protein, vitamin and mineral. Endocrine organs: regulate of carbohydrate, fats and protein metabolism, glucocorticoid, mineralocorticoid and sex hormone. uh, Hematologic organ: temporary storage of blood, remove of biliary from bloodstream. Hematopoiesis in certain disease stage, synthesis of blood clotting factor. Exocrine organ: excretion of bile pigment and cholesterol. Urea synthesis, detoxification of drug and other foreign substances like alcohol, attributable to hepatocellular failure and portal hypertension. Hepatocellular failure, jaundice, decrease in chlorine factor, hypovolemia, decrease in vitamin D and K, osteomalacia, vitamin D, poor blood in chlorine factor production, vitamin K, fermentation, portal hypertension, GI congestions, development of esophageal and gastric varices, hemorrhoid, splenomegaly, ascites. All these are complications of hepatic failure. Hepatocellular failure, clinical manifestation: jaundice, muscle wasting, ascites, impaired absorption of fat-soluble vitamin, altered lipoprotein processing, dyslipidemia. Hepatocellular failure, clinical manifestation: abnormal storage and release of glucose into form of glycogen, hyperglycemia, hypoglycemia, inadequate protein metabolism, decreased production of clotting factor, hypoalbuminemia, that's the one that lead to edema. We have impaired progressing of endogenous steroid hormone, estrogens in men produce gynecomastia, impotency, testicular atrophy, female hair distribution in women is rhabdomyolysis, pulmonary erythema, spider telangiectasis. Pulmonary erythema, spider telangiectasis also is present in male. Impaired clearance of exogenous drugs and toxins, conversion of ammonia to urea. Jaundice, characteristic sign of liver disease, green-yellow stain of tissue by bilirubin, result from impaired bilirubin metabolism. Pathogenesis of jaundice: we have damage of the RBC and release hemoglobin, heme and globulin separate, heme release iron and uh, biliverdin, bilirubin reductase, bilirubin unconjugated lipid soluble is released into the plasma and transferred to the liver by albumin. A special transfer protein in liver extract unconjugated bilirubin from plasma. In liver, bilirubin is bound to glucuronic acid by uridine disphosphate glucuronide transferase. Yield to water-soluble bilirubin excreted into the bile duct. Bilirubin as a compound of bile is transported to the small intestine, passes to the colon to be break down to urobilinogen and passes to the emphysis. A small fraction absorbed back into the circulation to be excreted by the kidney. Jaundice results from dysfunction anywhere along the pathway. Prehepatic causes: hemolysis, infection of erythropoiesis, reabsorption of large hematomas. Hepatic cause: dysfunction of the liver cells, increased liver level of conjugated bilirubin, immature urinary transferase glucuronide transferase. Physiology: newborn jaundice. Posthepatic cause, up level of canalicular bilirubin transport, conjugating hyperbilirubinemia, mechanical obstruction to bile duct, jaundice evaluation, complete history of physical examination, telangiectasis, ascites, palmar-erythema, gynecomastia, testicular atrophy, hair loss, underlying cause, alcohol, liver disease, drug reaction, metastatic or primary malignancy, diagnosis tech, biochemical assay, needle biopsy of the liver, ultrasound, CT, ERCP, MRCP, laboratory tests, hepatocellular disorder, hepatitis, significant elevation in transaminase out of proportion of other liver enzymes, alcoholic and toxic hepatitis, elevated SAT more than ALT. Those are the transaminase, okay? Those are the liver marker, okay? SAT and ALT. If the SAT is more elevated than ALT, most of the time is alcohol related. ALT is more related to viral infection, hepatitis, intrahepatic cholestasis, elevated ALP. Laboratory testing, hemolysis, extrahepatic cholestasis related to bilirubin obstruction and cirrhosis. Portal hypertension, sluggish blood flow resulting in increased pressure in portal circulation, congested venous drainage of the GI tract. Clinical manifestation, we have anorexia, varices, ascites, gastroesophageal varices. Etiology result from portal hypertension, alcohol and post-hepatic cirrhosis, infection from liver flake, vasoactive hormones, increased splenic blood flow, increased vascular resistance in the liver, pathogenesis of gastroesophageal varices, complex venous network surrounding the proximal part of the stomach and esophagus can rupture with critical high portal hypertension, lead to massive life-threatening upper GI bleed, collateral venous pathway dilate in response to elevated portal pressure. In Athens to transfer blood from her splenic bed around cirrhotic liver and back to her. Gastroesophageal varices clinical features affect about half of cirrhotic patients. Size is main determinant of risk for bleeding, variceal bleeding, mortality 50%, greater risk for re-bleed occur in the first 72 hours. Gastroesophageal varices clinical manifestation, hematemesis, melena, bright red rectal bleeding, anemia, shock, treatment, fluid resuscitation, normal saline via large bore IV lines. You have to put 2 lines. You as a future nurse have to know this. You have an internal bleeding, the first step is to put two bores line, okay, and give plenty of fluid to the patient, IV fluid, correcting the coagulopathy and stopping further bleeding with blood components and clotting factor replace, parenteral vitamin K, fresh frozen plasma, platelet recombinant factor 7A, treatment, vasopressor, nitroglycerin, osteolyte is the main medication that you give to those patients. Metoclopramide, H2 blocker, PPI, beta blocker is basically a prophylaxis. Emergency EGD, esophagoduodenoscopy, endoscopy, sclerosis. gastroesophageal varices treatment, endoscopic ligation of esophageal varices. Endoscopic techniques show mortality benefits compared to medication. Treatment: ballooning tamponade of varices. That's another type of treatment. Another treatment is the tips. That's the last option, okay? Because when you produce these transjugular intrahepatic protocysteine shunts, uh, that means that the waste product is not going to be eliminated by that organism. Okay? Liver transplant, esophageal transection, and reanostomosis, portal-cava, meso-cava, splenorenal, and distal splenorenal shunt. Hepatic encephalopathy, that's a complication when you do it. Okay. Pathogenesis, complex neuropsychiatric syndrome from too much ammonia. That's where you can get rid of the ammonia that goes to the brain and produce the hepatic encephalopathy. Associated with hepatic failure and severe chronic liver disease, exact cause is unknown. Hepatic encephalopathy, clinical manifestation, dementia, psychotic symptoms, splenic myelopathy, cerebral pyramidal signs, asteresis, that's you produce that you perform in the patient, ammonia level correlated possibly with the level of encephalopathy, mild confusion and lethargy to stupor and coma. Hepatic encephalopathy treatment: correcting any identifiable precipitating factor, restricting dietary proteins. Treatment: peripheral and central IV infusion with vitamin, high-fiber diet, amoxicillin and rifaximin suppress intestinal flora that break down dietary protein and release ammonia. Lactulose, that's the main medication. Cerebral edema, pathogenesis, swelling of the brain, cause decreased brain perfusion, major cause of death with acute hepatic failure, clinical manifestation, deep in coma, systolic hypertension, extensor rigidity, pupillary dilation, respiratory arrest. Treatment: IV infusion of mannitol, that is essential to decrease the intracranial pressure. Sodium ketotal, placed in semi-full position, moderate hypothermia, survival 60% with aggressive treatment. Ascites, pathology, accumulation of fluids in the peritoneal cavity, occur with portal hypertension and hypovolemia, occur with many other conditions. Diagnosis: fluid examination for abdominal paracentesis, total protein, albumin. Treatment: dietary sodium restrictions, bed rest, diuretic, paracentesis, tip and liver transplant. And we have question number 1. Question number 1 is: a patient have ascites. Which intervention is priority? What's the answer? Out of all those interventions, the one that is priority is restricted sodium. Okay? Remember that the water follows the sodium. Okay? And ascites is accumulation of water in the belly. Spontaneous bacterial peritonitis is bacterial infection in the peritoneal cavity, single infection organs of gut origins, risk cirrhosis. Ascites cause diminished reticuloendothelial function, transmigration of gut bacteria across the intestinal wall to ascites. Clinical manifestation: mild abdominal discomfort, general clinical deterioration, worsened hepatic encephalopathy, renal failure, not specific septic picture, significant fever, may be lacking. Diagnosis, this is essential, okay? You do abdominal paracentesis and the leukocyte has to be over 250. If you don't have this, there is no bacterial peritonitis. Treatment, antimicrobial therapy, third generation cephalosporin, quinolones, poor prognosis. Hepatorenal syndrome, acute and progressive disease, normal kidney with disturbance intrarenal blood flow related to imbalance between vasoconstriction and vasodilation mechanism, raising serum creatinine level and oliguria treatment, prognosis poor, preventive and supportive hemodialysis, liver transplant. In hepatorenal syndrome, you have to treat the hepatic condition, and when you fix the hepatic condition, the renal is gonna fix by itself, okay? Acute viral hepatitis. Acute viral hepatitis is inflammation of the liver parenchyma caused by many viruses, cytomegalovirus, Epstein-Barr virus, and then we have the viral hepatitis, hepatitis A, B, C, D, and the most important one, hepatitis B and C, okay? Especially by hepatitis C because we don't have vaccine for hepatitis C. We have vaccine for hepatitis A and hepatitis B. Hepatitis A is an RNA virus, also called enterohepatitis. Hepatitis A follow the A rules. Okay, A rules mean that it's acute. The first is hepatitis A is acute and also produce diarrhea. Also, it's called the traveling diarrhea. Okay, you go to another country and when you get back, you have diarrhea, and it's because of hepatitis A. Maybe you have jaundice, right lower quadrant pain, malaise, anorexia, and so on. It's self-limited course. That means that you don't have to do anything. Hepatitis A, serology testing, uh, hepatitis A virus, immunoglobulin G, immunoglobulin A, if acute infection, treatment support is avoid ethanol, acetaminophen, hepatotoxins, prevent carefully hand washing, segregation, cleaning of laundry and personal items, immunization, and gamma globulin. Hepatitis B is the biggest one, is the one that most of the time actually is tested in any exam. Hepatitis B is a partial double-stranded DNA, okay? It's the only one that is DNA. All the other ones are RNA. And let's keep going. Hepatitis A risk factor, perinatal healthcare setting, transfusion, dialysis, acupuncture, tattooing, residence in an institution, incubation period 2 to 6 months, predominant period, asymptomatic or rashes, arthralgia, arthritis, angioedema, serum sickness, glomerulonephritis, jaundice. Serology testing, we have the surface antigens, S for surface, C for core, and E for you have to remember this as an infective, okay? Because when you have the E, that means that the patient have an active hepatitis. Treatment, person with detectable viral and HBe antigens positive react transmit virus and their contact and should be counseled. Support this and liver transplant. Treatment interferon alpha, lamivudine, Adenofovir, Entecavir. Those medications are extremely hard. The pronunciation, memorization, and everything with those medications is extremely hard. Prevention immunization. Remember that we have a vaccine for hepatitis B, and it's giving at birth. Hepatitis B prevention, administration of hepatitis B immunoglobulin, continued high level of hepatitis B surface antibody given within 7 days of exposure. Indication: neonate born to hepatitis B surface antigen positive mother. Prophylactic after needle stick, sexual sport, after liver transplant in patients who are positive for that marker. Hepatitis C. Hepatitis C is a single strand of RNA from the flavivirus. It's also called non-A, non-B hepatitis. Hepatitis have 6 types. Hepatitis C have acute and chronic. Acute infection, usually asymptomatic, course if erratic with wide fluctuation of liver enzymes. Chronic is usually asymptomatic until advanced liver disease intervenes. Most common cause of end-stage liver disease with cirrhosis. Treatment for acute hepatitis: supportive and expectance. Early treatment not recommended. Treatment for chronic infection: assessed by viral load and viral genotype, liver biopsy to stage disease activity. Treatment for chronic active hepatitis C infection: vaccine against hepatitis A and B, consult regarding blood-borne precursor, Center for CDC and Prevention does not currently recommend barrier method for patients with long-term sexual partner because of the apparent low risk of infection. Hepatitis D. I'm not gonna read this PowerPoint. I'm gonna say the most important for hepatitis B and is the worst hepatitis in pregnancy. In pregnancy, hepatitis D is an emergency, and the most important for hepatitis D is that you need to be infected with hepatitis B to get hepatitis D. Okay, not specific treatment, prevention, safe sexual practice, avoid of IV drug user, vaccine of susceptible person with hepatitis B vaccine. There is no vaccine for hepatitis D, okay? Don't get confused. Hepatitis D E is an RNA. Prodromal and icterial illness usually lasts only 2 weeks, similar to hepatitis A infections. These two have uh, share some characteristics, okay? Because the E and A you could get it in through the oral, okay? Oral fecal infection. Okay, chronic hepatitis, group of disease characterized by inflammation of the liver that lasts 6 months or longer, cause autoimmune disease, viral hepatitis B and C, toxin, metabolic disease. Hepatitis B and C are the only ones that can produce chronic hepatitis. Okay, chronic persistent hepatitis, pathogenesis, chronic low-grade liver inflammation, and of any cause, also called choroiditis or transaminitis. Inflammation confirmed to portal trial without destruction of normal liver structure. Clinical manifestation: asymptomatic or mild, non-specific symptoms. Treatment: no drug treatment needed. Excellent prognosis. Chronic acute hepatitis progresses obstruction inflammatory disease of the liver lasting more than 6 months, extends beyond the portal tract and hepatic lobe, may progress to cirrhosis, clinical manifestation, fatigue, malaise, nausea, anorexia, ascites, hepatomegaly, abdominal pain, and jaundice. Chronic active hepatitis diagnosis, laboratory, abnormal liver enzyme, serology study, liver biopsy, and treatment depend on causes. Autoimmune hepatitis diagnosis, severe several antibodies, positive ANA test, high level of anti-smooth muscle antibody that's special for autoimmune hepatitis treatment, corticosteroid immunosuppressive drug, cirrhosis, irreversible end stage of many different hepatic injuries, severe acute hepatitis, chronic hepatitis, toxic hepatitis, metal storage disease, alcoholism, liver is fibrosis, scarring or nodular result in permanent alteration in hepatic blood flow and liver function, biliary cirrhosis, etiology and result of continuous ongoing inflammation of bile duct caused by biliary obstruction with resultant backup of bile into the liver, microscopic and large duct obstruction pathogenesis result in inflammation and scarring of the liver with obliterant of bile ductable, diffuse widespread fibrosis and nodular formation, portal hypertension. Diagnosis: appropriate serology result, liver biopsy, treatment, ursodeoxycholic acid, methotrexate, colchicine, and liver transplant. Flake from eating raw fish of contaminated watercress, aquatic plant from sheep, cattle, producing area, diagnosis, serious to specimen and serology testing, treatments, antiparasitic agent. Primary sclerosis cholangitis is an autoimmune condition generally seen with ulcerative colitis, pathogenesis, recurring episodes of cholangitis with progressive biliary scarring and obstruction and result in cirrhosis, predisposition to cholangiocarcinoma as cancer of the gallbladder, secondary form related to biliary duct injury during surgery, and primary sclerosing cholangitis is common in male. Diagnosis: ERCP or MRCP show typical bleeding and atrophy, appearance of biliary tract, liver biopsy performed for staging and disease. You have to be careful with ERCP and MRCP because that produce pancreatitis. Treatment: medical and endoscopy treatment are for palliative treatment, liver transplant. Alcoholic fatty liver. Pathogenesis is alcoholic steatohepatitis, fat accumulation in liver cell, cause more fat is delivered to hepatocyte that it can normally metabolize, defect in fat metabolism within the cell, clinical manifestation, usually mild and asymptomatic, liver enlargement, abdominal discomfort, portal hypertension. Diagnosis: hypertriglyceridemia, liver enzyme mildly abnormal, treatment: stopping alcohol intake, providing appropriate nutrients, non-alcoholic steatohepatitis, weight reduction, control of diabetes or hyperlipidemia, treat underlying cause. Alcohol hepatitis pathogenesis: active inflammation of central lobar region of the liver. Liver cells show pathology chain of hepatocyte necrosis with necrophilic infiltration and intracellular inclusion, Mallory bodies. cause alcohol binge in large quantity than usual, mortality rate 33%. Clinical manifestation: illness range from mild to severe, may be complicated by acute alcohol withdrawal or delirium tremens. Diagnosis: SAT is gonna be more elevated than ALT. Treatment: corticosteroid treat malnutrition and vitamin deficiency, thiamine, folate, vitamin B12, and vitamin K. Toxic liver disorder: liver is subject to damage because of its role in storage and detoxifying potential injury substance. Metal storage disease are genetic disorders in which excessive minerals are absorbed and subsequently deposited in the liver. Hereditary hemochromatosis and Wilson's disease. Hereditary hemochromatosis, etiology: one of the most common autosomal recessive disorders worldwide, prominence in Europeans. Pathogenesis: activity of mutant genes allow excessive and uncontrolled iron absorption. Iron deposits in numerous organs, especially liver, pancreas, and the heart. Can progress to hepatocellular carcinoma. Early diagnosis and treatment are critical. Clinical manifestation: liver is the first organ to show involvement, hepatomegaly, elevated liver enzymes, diabetes, mellitus, hyperpigmentation. That's one of the main characteristics of hereditary hemochromatosis. It's called Brown's diabetes. Polyarthritis, hypogonadism, heart failure. Also remember, you have hypogonadism, then that produces impotency. Diagnosis: clinical feature, family history, liver biopsy, laboratory, elevated plasma iron and transferrin saturations. Treatment is begin if ferritin greater than 1,000, deferoxamine chelating iron and facilitate its renal excretion, repeated phlebotomy, and liver transplant. And we have question number two. Question number two. A patient has cirrhosis. Which substance is elevated in the patient's body? Go. Who knows the answer? Hello? Okay, the answer for this question is A, iron. Remember, hereditary hemochromatosis is a lot of iron in your body. Okay, Wilson disease is copper. Wilson disease, etiology also known as hepatolenticular degeneration, rare autosomal recessive disorder, present less than 30 years and children, excessive amount of copper accumulate in the liver and other organs. Clinical manifestation: hepatomegaly, elevated liver enzyme, movement disorder, rigid dystonia, primary psychotic symptom. Diagnosis: clinical signs and symptoms, SIP-LAM examination, brownish Kayser-Fleischer ring, margin of the cornea, that's basically pathognomonic, genetic analysis, laboratory, low serum ceruloplasmic, that's another pathognomonic, because this is the one that allow the body to eliminate the copper. With disease treatment is eliminate copper-rich food, oral chelating therapy, especially this one, penicillamine, penicillamine, neurologic therapy, acetaminophen, Acetaminophen poisoning etiology can cause acute hepatic failure. Acetaminophen more than 100 mg per kilogram exposes liver to high level of toxic metabolite and acetylbenzoquinone. Normal, it is rapidly detoxified by liver enzymes. In overdose, detoxification reaction may be overwhelmed and liver necrosis result. Clinical manifestation: Patients surviving 1 week generally experience complete recovery, nausea, vomiting, diarrhea, abnormal liver enzyme levels. If untreated, progress to liver failure with jaundice, encephalopathy, hypoglycemia, coagulopathy, death. Acetaminophen toxin treatment: detoxify with induced emesis or lavage with active charcoal. Acetylcysteine. Liver axis pathogenesis: ascending biliary infections, abdominal infection transferred by the portal vein, and direct extensive of infection from neighboring structures are usually source of infection. Common organisms include anaerobic gram-negative bacteria. Liver axis clinical manifestation: we have fever, right upper abdominal pain, nausea, vomiting, hepatosplenomegaly, palpable mass, pathogenic infection, leukocytosis, elevated erythrocytation rate, liver enzyme. Liver axis diagnosis: ultrasound, CT with or without thin needle aspiration, gram stain and culture of material, blood culture. Treatment: CT, ultrasound guide percutaneous drainage, tube placed until drainage resolved, antibiotic therapy. Trauma: etiology: injury by penetrating abdominal trauma, gun or stab wound, rib fracture, injury by blunt abdominal trauma. Pathogenesis: highly vascular organs, receive approximately 29% of body cardiac output, massive blood loss with trauma. Clinical manifestations: possible hemorrhagic shock, right upper quadrant pain with cardiac or referred to shoulder, abdominal rigidity, tenderness, and distension. Treatment: administration of fresh whole blood, packed red blood cell, or fresh frozen plasma, massive fluid infusion, may be in ICU. Malignancy etiology: liver is a common site of metastasis of primary cancer, esophagus, stomach, colon, rectum, breast, and so on. Primary liver tumor rare in the United States. Hepatocellular carcinoma is most common form of primary hepatic malignancy, referred as hepatoma, common in middle age, men and women, increased in the United States, related to increased hepatitis B and C prevalence. Hepatocellular carcinoma, clinical manifestation: hepatomegaly, abdominal pain, nausea, weight loss, jaundice, ascites, paraneoplastic syndrome. Diagnosis: alkaline phosphate elevated, alpha-fetoprotein is often dramatically elevated, ultrasonography, CT, and magnetic resonance images may not need a biopsy. You have to do an image always for diagnosis, okay? Because alpha-fetoprotein and alkaline phosphate, especially alpha-fetoprotein, is a tumor marker, and you follow the alpha-fetoprotein to see if the treatment is working. Treatment: hepatic resection, partial resection, complete hepatectomy followed by liver transplantation. Hepatocellular carcinoma treatment: chemotherapy, palliative therapy, and there is new drug for that treatment, and transplantation. Candidate end-stage liver disease not responding to Conventional medical surgery interventions include adult and children's orthotopic transplant, rarely performed for malignant neoplasia. Evaluation of transplantation: Patient undergo extensive psychologic and physiologic evaluation. If no contraindication, patient is defined as candidate. Surgery after donor organ uh, recur 8 to 20 hours to complete. Post-transplant management: immunosuppressant prevention reactions. Most often reactions represent post-op day 4 to 10. Immunosuppressive drug, appropriate vaccine. Post-transplant management: clinical manifestation of organ rejection, tachycardia, fever, right upper quadrant flank pain, diminished bile change in color, increased jaundice. Post-transplant manifestation: treatment of acute rejection, high-dose corticosteroid is not response to corticosteroid, urumumab, mycophenolate mofetil. Chronic rejection: progress duodenopenia and recurrence of primary transplantation liver disease. Liver disease and pediatric consideration: abnormal bilirubin metabolism in the neonatal period, physiologic jaundice of the newborn, harmless condition lasting no longer than 2 weeks after delivery, cause immature bilirubin conjugation and transfer mechanism, increased gut absorption of bilirubin, breastfeed, bottle-fed babies, B-glucuronidase in breast milk result in increased unconjugated bilirubin in the gut. Kernicterus. Kernicterus is when you have the jaundice uh, in the brain, okay, with the bilirubin in the brain, and that produce a lot of neurologic manifestation. Kernicterus etiology: premature cell death from apoptosis. Survivor can suffer from cerebral palsy, movement disorder, and mental retardation. Treatment: drug that displace bilirubin from albumin. Seriously worsened condition: exchange transfusions, phenobarbital, phenotherapy. And we have question number 3. Question number 3, a nurse is asked about kernicterus. How should the nurse reply? Kernicterus in the neonate. What's the answer? Okay, kernicterus causes brain injuries, always, and encephalopathy. Encephalopathy means inflammation of the brain. We keep going with the pediatric: infection of acquired hepatitis in children, acute hepatitis A infection, mild or asymptomatic, prevalence correlate with quality of sanitation and hygiene, treatment is supportive, prevention, always we have the vaccine. Remember, hepatitis A and B, we have vaccine. Hepatitis B infection, common childhood disease, vertical transmission from HB surface antigen positive mother to infant, give infant immunization within 12 hours of birth, infect blood product and drug. Chronic infection is highly after neonatal or childhood infections. Children's hepatitis C virus, less commonly spread vertically, affects screening of blood products, have greatly reduced risk of infection. Hepatitis delta virus, spread by intra-family route as a co-infection with hepatitis B. Hepatitis E, common in adolescent and young adult, most common cause of childhood hepatitis, indirect cause of infant mortality. Uh, okay, clinical hepatitis caused by many viruses, find of the enlarged liver and elevated transaminase assays for congenital infections, part of the so-called TORCH syndromes. Reyes syndrome is primarily a disease of children, occurs shortly after a viral infection, influenza or chickenpox. A strong association with aspirin, okay? That's why you have to avoid aspirin in children because that produces Reyes syndrome, characterized by fatty infiltration of liver with severe hepatic dysfunctions, encephalopathy, coagulopathy. Clinical manifestation: nausea and vomiting, rapid progresses to coma, treatment, mortality as high as 40%, supported. Each child survives, recovery is complete, liver transfers are reserved for irreversible disease. Congenital liver disease categories: we have enzyme deficiency affecting multiple organ systems, alpha-1 antitrypsin deficiency, fibrosis, disorder of bilirubin metabolism, Klicker-Niggard syndrome, inborn error affect other metabolic pathway, intrahepatic ductopenic condition, extrahepatic ductopenia, biliary atresia. Alpha-1 antitrypsin deficiency is an autosomal recessive condition found mainly in children and young adults. Alpha-1 antitrypsin is an enzyme inhibitor found in many tissues. Normal prevents elastase and collagenase from damaging tissues, genetically controlled by the gene with many allelic variations. Pathogenesis: defects in alpha-1 antitrypsin protein accumulate in the liver, produce diagnostic granules. Clinical manifestations: central lobar emphysema, pancreatic insufficiency, cirrhosis. Treatment: gene therapy. Cystic fibrosis is an autosomal recessive condition that causes lung disease in children. One of many mutations in a single large gene on chromosome 7 that encode the cystic fibrosis transmembrane conductance regulator protein. Clinical disease requires disease-causing mutation in both copies of the CFTR gene. Complication: pancreatic insufficiency, that's one of the main complications, intestinal obstruction, gallstone disease, neonatal giant cell hepatitis, bile duct obstruction, biliary cirrhosis. Treatment: direct at complication, gene therapy, ursodeoxycholic acid. Now we have X-linked adrenal leukodystrophy, one of the many hereditary peroxisomopathies. Peroxisomes are responsible for final step of bile acid synthesis. Clinical manifestation: progressive neurologic dysfunction of the adrenal insufficiency. Those conditions are extremely weird. Okay, maybe you never in your life gonna see a patient with those conditions. Cerebrotenitis xanthomatosis, disorder of bilirubin metabolism related to steroid hydroxylase deficiency. Clinical manifestation: premature atherosclerosis, encephalopathy. Treatment: chenodeoxycholic acid show marked improvement. Gilbert syndrome pathogenesis is disorder of bile acid transport, very common. Benign autosomal dominant condition: those are patients that under stress they develop jaundice. Klicker-Niggard syndrome pathogenesis: rare autosomal recessive disorder, marked by significant unconjugated hyperbilirubinemia. We have type 1 and type 2. Type 1, present shortly after birth, neonates usually die of kinitury or suffer irreversible neurological damage. Near or total absence of bilirubin conjugation, treatment, liver transplant after phototherapy, plasma exchange transfusion. Type two, some conjugation capacity exists, enhanced by administration of phenobarbital, can lead to normal liver, not encephalopathy, treatment, phototherapy, possible liver transplant, and gene therapy. Progressive familial intrahepatic cholestasis, rare autosomal recessive disorder with effect in bile salt excretion, clinical manifestation, severe jaundice, pruritus, malabsorption, treatment, ursodeoxycholic acid, biliary diversion procedure, fetal unless received liver transplant. Inborn error of metabolism, pathogenesis, enzyme anomalies result from single gene mutations, generally autosomal recessive, results in abnormal processes of lipids, lipopolysaccharide, glycogen, amino acid, and protein. uh, Excessive accumulation of precursor substance in target organ, liver is the main site of processing and may be target of toxin accumulation. Treatment, liver or bone marrow transplants. Intrahepatic cholestasis condition, cholestasis liver disease in which a pathologic process is confined to the liver. Extrahepatic biliary system is normal. Cause neonatal hepatitis, condition in which number of bile ducts are decreased and inadequate. We have Alageli syndrome. Those conditions, I'm not gonna read this one because that is an extremely rare condition. You are never gonna see patients with those conditions. Biliary atresia, this is not a common condition, but it's a condition in the neonates. Biliary atresia, progressive obliterate cholangiopathy, also called extrahepatic duodenopathy, congenital or acquired, common birth defect, occur in certain autoimmune illnesses, principal form of chronic rejection of the transplant liver allograft. Clinical manifestation, progressed cholestasis with all the usual features. Diagnosis, cholangiogram and liver biopsy. Treatment, calcite procedure, creates hepatoprotein connections, and liver transplant. Liver disease and geriatric condition. Geriatric condition is adult, okay, elderly patient. Liver size and blood flow decrease with aging, carefully monitoring of medication that affect hepatic blood flow and proceed by cytochromes, hepatocellular carcinoma, ischemic hepatitis associated with cardiovascular disease and episodes of hypotension more common in all patients, rapid elevation of serum transaminase and prolonged PT. Recovery may be rapid but depends on severity of underlying disorder. Hemochromatosis in women occur after menopause, may have new onset of diabetes mellitus, heart failure, arthritis, cirrhosis, and hepatocellular carcinoma. Autoimmune liver disorder, autoimmune liver disease, chronic active hepatitis may be cause of cryptogenic cirrhosis in older women, primary sclerosis cholangitis. We already covered primary sclerosis cholangitis, alcohol abuse, cumulative injury of years of exposure shows signs of advanced disease, intoxication and hepatic encephalopathy may be confused with senile dementia, made worse by concomitant drug use, treatment, same as younger patients, no social circumstance, concurrent medical problems, acute viral hepatitis, more difficult related to non-specific symptoms and decreased clinical suspicion. Acute hepatitis B infection, this is the same for any age, okay? And right here, this is the end of this chapter. You have a case study. This case study is for all of you to study, okay? You go over the case study and then you answer the question, you see? And it's for you to study. You don't have to do anything. You don't have to answer that. You don't have to do any paper, okay? Let me stop the recording right here because that class was extremely long.